afternoon. Welcome, everyone. We're so happy you can join us today. We are going to start off by saying we have a little bit of technical difficulties, but we think we've worked through it. So Jessica Setnick is here with us. You cannot see her, and her audio wasn't working awesome through the GoToWebinar app, and so she's calling in on her phone. So I think you'll be able to hear her just fine, but bear with us just a little bit as we do some switching and changing and making sure that she can advance her slides and that you all can hear her. So we appreciate your patience. We're starting just a couple minutes late, but hopefully we'll be able to get everything rolling here easily. So before we get started, let me introduce myself. My name is Tamara Bingham Noyes. I'm the Director of Business Development at Center for Change. I just celebrated my 14th year anniversary at Center for Change. It's a place that I love, and it's near and dear to my heart, and I'm so happy to be with you all today. A couple of housekeeping things before we get rolling. So the first one is that a copy of the PowerPoint is in the handouts section of the toolbar. There are also a couple of other handouts there that Jessica wanted you all to see. If by chance you aren't able to access them in the toolbar, they are also on our website. So you can go to centerforchange.com, click on the Professionals tab, then click on the Webinars tab, and you'll see all of that information there. A copy of the post test is also in the handout section of the toolbar. This is for reference only. In order to obtain continuing education credit, you must take the online post test, and I'll talk about that in just a minute. You're welcome to submit questions in the questions section of the toolbar. We'll try to get to some at the end of the webinar. And in fact, Jessica is going to end her slide presentation about 10 minutes or so early so that we have plenty of time for questions. Jessica has been a presenter at the Center for Change conference for several times over the years, and she always gets a ton of questions, which is great. But therefore, we sort of have planned ahead a little bit so that there'll be some extra time at the end of the presentation so that we can get to some questions. So there are lots and lots of you online, so in attending. So, you know, obviously we have you muted. Please stay muted if you would. There are hundreds of you on here. So if you unmute, then we have to kind of stop and remute everyone. So if you'd be so kind as to stay unmuted and then type in your questions, then I'll monitor those throughout Jessica's presentation. And then at the end, we'll try to get to as many of those as we can. When the webinar ends, there's an evaluation that will pop up. If you would take 30 seconds or so to complete that evaluation, that would be really helpful for us. This is a continuing education requirement for us. It's completely anonymous, so please feel free to be candid in your feedback. And if you'd fill out that evaluation when it pops up, that would be great. We tabulate those results and send those to the CE entities per their request. And then lastly, about an hour after the webinar ends, you'll receive a separate email with the link to take the online test. You must take the test online and pass it in order to receive continuing education credit. Once you pass the test, then the CE certificate will automatically be downloaded to your computer. So watch for that. If you can't see it on your screen, check your downloads file. It may be hiding there. Okay, we're going to turn it over to Jessica. Jessica, are you there? Uh-oh. Hang on, we'll see if we can get this resolved. Bear with us, everybody. It's been a bit of a ride so far, but we're going to figure it out, hopefully.
I'm here.
There we go. Now we can hear. That's awesome. All right, Jessica.
Sorry,
Okay. You're totally good. Let me change the presenter to you so that we can see your screen. So it's coming your way.
Okay.
Hang tight.
Okay, great. Oh my gosh, technology is conspiring against me today, but I will be victorious.
That's right. You will prevail, and you have. I can see your screen, so we are good to go, and I can hear you great. So I'm going to go ahead and turn off my microphone and my camera and turn it over to you. Then when you're ready for questions, then I'll pop back up, and if there's a problem in the middle, you'll also see me pop back up. So holler at me if you need something. Otherwise, you can just go for it.
Okay, so first of all, I would like to say that it might be helpful just for this first few minutes of my introduction is if you consider putting down your pens and even considering closing your eyes if you'd like to. I heard somewhere that vision takes up so much of our brain power that actually when we close our eyes, we become something like 25% smarter. So I'm not talking about any of my slides at the moment, so you won't miss anything. I just wanted to talk for a minute about superheroes. If you have a favorite superhero, think about their origin story, especially if the first time you encountered them, say in a movie or a TV show or a book or a comic. Wasn't it amazing when you learned where they came from and how they became who they are? Because the backstory is really essential to a character and how and why they make the decisions they make, even if that person themselves isn't completely aware of them. Now, anthropology starts as the discovery of the origins of the human race, the piecing together of the elements of what we have now with the elements and relics we can find of the past. The study of anthropology is helpful and useful because there's no possibility of moving forward without the past, even the parts we deny or are unaware of or that have been kept from us on purpose, because there is no us without the past. So I named this talk The Anthropology of Eating, which I think is kind of a big mystery. So kudos to you for coming to a talk that it may not have been clear at all what it was going to be about. The anthropology of eating to me is not how humans develop eating behaviors, but it's everything that's still a part of all of our eating. So the changes, for example, that humans made, some humans went from being migratory people to living in one place. The way agriculture was both a cause and effect of that change of residence, the way our physical stature changed due to agriculture, the way we were able to build environments around us because we were staying in one place, the way that European colonialism recognized certain foods, behaviors, and ways of eating as acceptable and others as savage, the experience of drought, famine, conflict, gender divisions, other environmental and social influences, the experience of human trafficking and enslavement, world wars, regional conflicts, the Great Depression, the Vietnam and Korean Wars, Afghanistan. These are all things that contribute to what's going on with the experience of being a human right now. And for most people, being a human also includes being an eater. So anthropology really looks at everything that's going on behind the scenes, which, although we may attempt to just be observers, does in fact change what's going on just by our presence and our observations. And it really incorporates 4 features that can also be applied to eating. And that is the physical development of humans as a race and later in subgroups. So that's physical anthropology. The social development of humans as a race and then later in subgroups, and that's cultural anthropology. The development of communication and language in humans as a race and then later in subgroups, which is called linguistics. And then even the ways in which we die, which is called forensic anthropology. So with that background on what anthropology is, I'll bridge to the anthropology of eating, which it's just the words I put together to attempt to describe and use the strengths of anthropology to determine the origins of an individual's eating dysfunction. Because that's what I think most people on the call, without knowing exactly why you decided to sign up for this call or webinar, and what area you work in, or if you're an individual who's personally experienced an eating disorder or both, that the origins of each individual's eating dysfunction can't be separated from the origins of our ancestors' eating and the origins of our eating as a society and the origins of our eating as a community of humans. So in order to improve recovery and point the way to the right methods for recovery, we need to understand the origins of each individual's eating dysfunction. And that may be exactly what you are doing in your practice. I suspect it is if you're working in an individual practice. If you're working in a facility or hospital setting, you may have to do crisis management before you can look at the origins of someone's eating behavior. But it's also possible that you were trained in a model that doesn't care about the origins of someone's eating behavior. And I'm not here to tell you that I'm right or wrong, just simply to provide options for something to, a way of looking at eating disorders. Now, my take on this is that without understanding the origins of behavior, our treatments are essentially just throwing spaghetti at the wall, hoping something sticks. But when I say that, depending on your ego involvement or your loyalty to the systems that we're in, you may feel like it's, I'm somehow threatening what you believe. And I want to just invite you to notice that. It's part of the way that we're trained in general. We may use words like non-compliance or treatment resistant to disguise our own failures because it protects our egos and our systems, when truthfully, our treatment failures are failures of treatment methods to succeed. So you may be identifying your own level of ego involvement and loyalty to your systems right now as I speak. And if you want to think about that more, consider what it would mean if something you know about eating disorders is wrong. What if everything you know about eating disorders is wrong? I'm not saying it is, but the more discomfort you feel around those statements, the deeper you're invested in what you know is right rather than being invested in finding the truth. So I'm only one person. I'm not invested in being right or even in you agreeing with me. I do know many of you do agree with me. And for those who think I'm wrong as I talk, I invite you to jot down your notes or share your questions and comments in the chat so we can discuss it later, because this is a work in progress, this model, and it's open to discussion. It's open to development. It has already developed since it was created 8 or so years ago. So if you had your eyes closed and you weren't taking notes, now is the time to open and grab your pen, because here we go into the anthropology of eating. The first thought I have about eating disorders that I mentioned is the fact that what we don't know about eating disorders is so huge. If you are new in the field, it may feel like this is a fully formed field that you came into with rights and wrongs, with protocols, and it's already developed. But what you need to know is that this field is really still in its infancy. If you remember that you couldn't even get a diagnosis of binge eating disorder until 2013, couldn't get a diagnosis of bulimia until 1986, depending on your age, that may actually seem like a long time ago. But in the big picture, it really isn't a long time ago. We are really in the stage of not knowing what causes eating disorders, not knowing what cures eating disorders. We can't point to the broken part like you could with a kidney or a leg. And we are still very much in the infancy of treatments for eating disorders. We can't predict what someone's prognosis will be. If you have personally recovered from an eating disorder, you may have ideas about what helped you, but there's so much happening physiologically under the surface that we still don't understand. Our own interpretations of what our eating disorders were about may not actually be correct because of all those things that I mentioned before. So this is my visualization about it, is that, what we know about eating disorders that's correct is small. We know a few things. What we don't know about eating disorders is very big. And what we think we know that's actually wrong is probably pretty significant too. Now, this is not meant to specifically identify any individual as being wrong, just our field in general, our society in general. Big picture, we are not very knowledgeable. Even if you've got a PhD in it, you're not very knowledgeable about eating disorders because you may know everything there is to know and still not know very much about eating disorders. So that's my humility in saying what I know is what I've learned in 25 years in this field and my personal lived experience, but it's certainly not everything there is to know. I look forward to the day, maybe 50 or 70 years from now, when whoever is working in the field looks back and says, I'm kind of amazed that they helped anyone at all. It's kind of a miracle. And I think you can think that every single day. Anyone that you're able to help is absolutely a miracle, considering we don't know what the root of the problem is. So kudos to you for going every single day into other people's pain without knowing for a fact that you'll be able to help them. Here we have a list of the official eating disorders and their codes, but I'm skipping right over this to say that there are so many more things that are not considered eating disorders only because they don't have diagnostic criteria. So just some examples from this list: chewing and spitting out food, under administering insulin to lose weight, chronic lifelong dieting. Everything else on this list is essentially some kind of dysfunctional eating behavior that does not have a diagnosis. And so starting here, we are not going to talk about eating disorders and diagnoses unless you want to use those words if they are, something that helps you explain to me something about your question. But for me, eating disorder diagnostic criteria are standardized so that people can talk about eating disorders among each other, and they're not very effective at that. So for example, if you were to call me for advice and say I have a patient with ARFID, I would encourage you to say something like, my patient has been diagnosed with ARFID. Here's what I've uncovered during my assessment. Because the diagnosis of ARFID doesn't give me any information about your patient. It only tells me what one individual diagnosed this person with. It doesn't even mean that diagnosis was accurate. It may mean that they meet those criteria, but there's so many other possibilities that don't represent the human experience of eating. And we know that from the old eating disorder not otherwise specified, which 66% of patients in the hospital for an eating disorder did not meet criteria for anorexia or bulimia nervosa, so they got the EDNOS. It's starting to happen with UFED, which is unspecified feeding or eating disorders, which is supposed to be an emergency diagnosis. For example, if someone comes into the emergency room unconscious and it's unclear what kind of eating disorder they have or incoherent and they cannot explain what's going on, that would be the temporary diagnostic use of UFED, as opposed to what's happening now is people are getting that unspecified feeding or eating disorder as a permanent diagnosis. So the diagnostic criteria are not ideal. And so from now on, we're going to call eating problems dysfunctional eating behavior. Now, don't panic over this slide, because this is one of the ones that you have as a completely independent handout. So you don't have to try to write down everything here, because we'll go over it individually. But the origins of dysfunctional eating behavior is named that because it's not particular to any one diagnosis. So dysfunctional eating behavior includes everything that we've come to think of as part of or a symptom of or a behavior of an eating disorder. So that could include undereating, it could include overeating, it could include, I would call that non-hunger eating, but it could include any number of things related to eating. It could also include exercising and over-exercising if it's related to eating. It could also include self-harm if it's related to eating. And I know there's some eyebrows that just went up and said self-harm isn't an eating behavior, but I thought that dysfunctional eating and eating-related behaviors was a little bit wordy. So we're going to include self-harm if it's related to eating. For example, after someone feels shame or guilt for eating or not eating, if there's a self-harming behavior, then we'll consider that an eating behavior. Any kind of purging or compensatory behaviors is included here in dysfunctional eating behavior. So what you see is that there is no differentiation at this point in the model in what someone's dysfunctional eating behaviors are. If you've worked in this field for any length of time, you know that most patients don't have one behavior. They may have an undereating behavior plus an overeating behavior. It might be in the same day, same week, same month, same year, but most people don't fit into those constructed boxes that we try to get them to fit into. And from the anthropology point of view, we try not to pre-assume about people by putting them in boxes, but instead try to go where the evidence leads us and the information that we uncover. So this is the model that we're going to go through step by step by step. And again, I encourage you to write your questions in the question or the chat so that Tamara can read them to me at the end. I have my chat closed right now so it doesn't distract me, but I will look forward to your questions and comments. So the first type of dysfunctional eating behavior we're going to talk about here are those that are biology-based. And when I created the model, I specifically used the term biology-based as opposed to genetics, because genetics is a part of biology-based, certainly, yes, but biology also is, genetics is also a word that essentially means different things to different people. And so, in some situations, you might hear someone say that, a genetic eating disorder means something that is passed on through families, but now we know that there's epigenetics, which is how your environment affects your genes and their expression. So there's a lot of things that are not necessarily genetic or hereditary related to biology-based dysfunctional eating. And so, yes, certainly there are eating disorders that are caused by genes, some that are caused by genes interacting with environment, some that are caused by environment interacting with personality, some that are caused by brain damage, closed head injuries, concussions, those kind of things. And also there are biology-based disorders that can then relate to eating. For example, obsessive compulsive disorder or anxiety or depression or any kind of medical condition, cancer, infectious diseases, that kind of thing. There's so many different ways that biology can influence eating. And it's so important that we identify this, because if you come from a background of, let's say, a behaviorist background where everything that is mental can be solved by thinking your way through it, it's really easy to miss some of the biological bases of behavior. So in a society where, for example, things are, let's say, much simpler and there are a lot fewer influences, let's say 1,000 years ago, we didn't have a lot of technology. Let's say that someone wasn't eating. Well, they might be able to trace it back pretty easily, or their family member could trace it back pretty easily. Well, my kid bonked themselves on the head, and ever since then, they haven't been eating very much. Now it's a lot more complicated. Someone gets a concussion, let's say a college athlete gets a concussion and isn't eating very much. There's so many possibilities and so much that we can sort of layer onto that. Well, the reason they're not eating is because they're not allowed to exercise anymore. And so they're worried that if they eat the same way, then they might gain too much weight in a fat-phobic society, and then therefore they don't want to eat anymore. Or we could make up all kinds of reasons why someone might not be eating enough, when the truth is there are physiological consequences of concussion that lead to alterations in appetite. And if we ignore that and we just try to cajole someone into eating by making, some kind of statement based on our assumptions, we're not actually treating the root of the problem, which is the person has alterations in their appetite. And if they don't eat adequately, then their concussion is not going to heal. And so we have a lot of situations where our layering on of an explanation, it does not look into the biological basis of some of these dysfunctional eating behaviors. Another clear example is PANS. On this handout, it's listed as PANDAS, but the name has now been changed to PANS, Pediatric Acute Onset Neuropsychiatric Syndrome. If you haven't heard of it, what it is when a child has some kind of illness, whether it's strep or mono or I believe COVID-19, although no one's really talking about it, but maybe 6 weeks to 6 months later, they develop acute onset symptoms of either obsessive compulsive disorder, generalized anxiety disorder, or anorexia nervosa. And it's going to look just like, let's use the example of anorexia nervosa, just like every other anorexia nervosa we've seen, someone who is not eating enough to sustain life. But if we, let's say, treated someone, 11-year-old, with PANS anorexia, with any kind of treatment is not going to work until they get the antibiotic and steroid treatment that is considered the best treatment now for PANS. So it doesn't matter how many therapy groups they're in, they're not going to be able to think their way out of it. Another example is Prader-Willi. Prader-Willi is a metabolic genetic disorder. It's not hereditary. It's a mutation where someone has an insatiable appetite and is unable to ever feel satisfied. This may be someone who is panhandling for food as a child, or going in the trash, eating other kids' food. Someone who is literally never, ever feeling like they've had enough to eat, even when their caregivers identify that they seem to have had more even than what might be normal, even to the point of where they might be throwing up their food involuntarily because they've eaten so much. And so this is another example of a purely biology-based dysfunctional eating behavior that can be misunderstood as a psychiatric binge eating disorder. And it will not be effectively treated by any behavioral methods or any psychiatric medication. It has to be treated in its own way. So when we come at eating disorders from any one pure sort of stance without being open to the fact that there are other features or other factors that are driving them, we miss out on the opportunity to have effective treatment. Another example is sleep disorders. I think night eating syndrome and sleep disorders are often very much confused, and night eating syndrome is treated as a behavioral problem, whereas a sleep disorder is something that's treated medically, when in fact I think often they're very mixed up together. And so the importance of identifying the biology behind dysfunctional eating behaviors is not just a theoretical exercise. It really has the goal of better treatment for individuals. So the treatment for biology-based dysfunctional eating behavior is pharmacology, which is specific to whatever the co-occurring or underlying condition is. If that's someone that has depression, we need to treat their depression, right? That's an obvious one. If someone has food allergies that make them scared to eat, we have to do education on the food allergies and address the fears. It has to be a complete holistic treatment rather than just one or the other of the pieces. There's also brain-based interventions, things like transcranial magnetic stimulation. There are things that probably haven't even been invented yet as far as brain-based interventions. And then, of course, nutritional restoration is always going to be important for someone who is malnourished, because malnutrition is a biology-based dysfunctional eating, is a cause of biology-based dysfunctional eating behavior. So it's very important that we address the biology-based aspects of dysfunctional eating behaviors when needed. And I just want to add, I put on this slide this COVID molecule, which I'm sure we've all seen so many times and are sick of, especially those of us who thought we were through with COVID and find out we're not. But I do believe that we're going to be seeing a lot of PANS-related COVID problems or COVID-related PANS problems, especially in kids who are asymptomatic, and then 6 weeks or 8 months, 6 weeks or 8 weeks or 10 weeks or 12 weeks later are going to have pretty severe psychiatric issues. And most people are not going to think, oh, maybe it's because they had COVID 6 weeks ago, because it may not have even been symptomatic at the time. But it's the autoimmune response and the acute onset that really differentiates this kind of eating disorder. And hopefully we will catch some of this before it becomes lifelong and, ineffective treatment. I also want to mention these are all in your slides. So even though I'm speaking of them sort of in a not linear fashion, you have all the dots and bullet points in your slides as needed. Okay, next I'm going to go on to the addiction-related dysfunctional eating behaviors. And these, I think, are caused by alterations in brain chemistry that are either due to substance use or the genetic predisposition to addiction, or could possibly be the trauma and stress that leads to addiction, and also the attempts in our society to use medication to control weight. And I think that is something that probably, it's not new, but it started, around the time when we humans figured out how to, in some parts of the world, have enough to eat for the first time. Instead of being excited that we had enough to eat, suddenly, due to social reasons, we decided that it was now a sign of being dignified to eat less. And therefore, we developed all kinds of everything from snake oil to fen-phen to ostensibly cause someone to have a different body size, and that can also lead to its own kind of addiction. So I think there is, of course, a biological aspect to addiction, but it's enough of its own type of dysfunctional eating behavior to have its own section. And so with the addiction-related dysfunctional eating behaviors, we're also seeing, as our sort of society advances and we look at the cultural anthropology, that there could be a lot of computer addiction, social media addiction, e-gaming addiction that could lead to eating problems. Part of it, yes, it's sort of the social aspect of comparison, and we'll talk about that when we get to the social and learned dysfunctional eating behavior, but also the dopamine dots that we get every time we, do something that feels over time addictive and distracts us from our internal cues for eating and satiety. So there's lots of things that can cause addiction-related dysfunctional eating behaviors. The treatments are really, a lot of times the treatments that we already use for addictions can be used for treating addiction-related dysfunctional eating behaviors, but in some cases they don't work. There are individuals who have told me that, kicking heroin was easier than not eating or then starting to eat again. And so it's not necessarily true that what works for one will work for the other. So we do have some things that we need, like pharmacology, but there's also things like 12-step programs and sponsors and specifically addiction pharmacology, things that are really helpful for people who have other addictions. And then there are things that are going to be helpful for people who, not as helpful for people who have addictions. For example, the abstinence model may be helpful for someone who's addicted to a substance or a problem behavior like gambling. We all know abstinence from food is not an effective methodology of treatment for an eating disorder. So it depends on each individual, because there are, I should say, there's always exceptions, and there are people who abstinence from certain foods helps them in their recovery. So, it's really hard to know what all the treatments are. That's the part where our field is still evolving, but we have to be able to separate out what is addiction related from what is one of these other two types of dysfunctional eating behaviors, which are coming next. The next section is the stress and trauma-based dysfunctional eating behaviors. And we know that trauma and stress cause changes in brain functioning. Now, stress and trauma, we could define those in many different ways. I will define trauma as an event, and I will define stress as ongoing, but that's not anyone's specific definition except for mine. There are, catastrophic traumas that are, the big events, and then there are sort of what's sometimes called little t trauma, which is sort of the trauma of neglect or failure of attachment and attunement. But to me, those don't seem very little at all. Those seem like very important, major events in life, although they're ongoing. So that's why I use the word stress to describe them. I also think there's internal stress, right? We have internal stress that comes to us from our ancestors, from the way we were brought up. But even if those individuals are no longer living or no longer in our life, we still have that internal drive. Sometimes there's also external stress and pressure, of course, related to our society, our family of origin, any kind of abandonment or neglect by a family of origin. There's also the chronic trauma and stress related to the systems that we live in. So, for example, being a person of color in this country, living in poverty in this country. Of course, this applies to people in other countries too. It's simply that I'm limiting my remarks to people in this country because that's where I believe, unless I'm incorrect, most people on this call are treating patients. If I'm wrong, please let me know in the comments. So we know that food insecurity causes traumatic changes in the brain. We know that malnutrition and food neglect, which I've recently learned is a terminology for someone who is malnourished, even though they live in a home where there is enough money for food, but for whatever reason they are restricted from food. Those kind of things affect brain development. They affect health in general. They affect hormone level like cortisol, et cetera. And so they ultimately affect brain development, structure, and function. And so trauma and stress-based dysfunctional eating behaviors also have a biological base, but they are based in the biology of all humans as opposed to specific biological dysfunction, like the first column. So trauma and stress-based dysfunctional behaviors have a huge effect on eating because they are often co-occurring with other situations. And that's why this section is so big on the handout, because you're talking about post-traumatic stress, you're talking about a chronically stressful childhood, you're talking about, in some cases, having lived in an orphanage or in foster care, you're talking about deaths and bullying and imprisonment and all kinds of things, including just the daily chronic stress of trying to either support a family, support oneself, pay for an education without any family funding. There's all kinds of things that are stressful that affect eating because of the way biology works. And so the treatment for these things is pharmacology in some cases for the concurrent conditions, also, of course, nutrition, counseling, and sometimes very specific trauma treatment methods like EMDR and somatic experiencing, grief, loss, or crisis support groups, whatever is appropriate to the stress and trauma that someone has been experiencing, whether it's individual to a family, whether it's a community stress like a fire that takes out a whole town. There's so many things that cause stress and trauma, and if we don't identify And again, in a crisis situation, you can't necessarily identify all these things before helping someone to move forward with their eating. But to ensure long-term recovery and the best possible prognosis, we have to figure out what exactly are the issues and how potentially to heal them. Not that every traumatic event can be healed, but how to separate that healing process from the process of nourishment as much as possible, or at least bring someone's understanding that these things are related so that they can make choices based on the facts rather than on the layer that someone else puts on top of it. And I will add that living in a fat-phobic environment is definitely traumatic. Having, experienced weight stigma or weight bias from medical professionals, having experienced racism, those kind of big picture systems problems are what I mean when I say that there is trauma in systems in the big picture as well as individual. And then finally, our last section is the learned dysfunctional eating behaviors caused by peer pressure or body dissatisfaction or, the messages that we receive, things like, forced dieting or withholding food trends like cleanses and things like that, athletic weight requirements, job weight requirements, military weight requirements, all kinds of things that are no less severe because they're social and learned, but their origin is from a specific message about food and bodies rather than the outcome of a different kind of stress or illness. So you have a well person who's basically had an eating disorder created for them by something iatrogenic or something that is part of our society or culture or their smaller culture within their family or their smaller group. And so when you see something like this is where, yes, we have to do all that nutrition education and counseling and anti-bullying work and media literacy and self-esteem and those kind of things. But you can see how, hopefully you can see, that the same things that are going to help someone who has a social and learned dysfunctional eating behavior are not the same thing that are going to help someone who, let's say, has dysfunctional eating behavior because they developed PANS or because they have an addiction or because they had a traumatic childhood. And so we have these outcomes which are, let's say, all these individuals are not eating enough to sustain life, but there may be very different reasons behind them. And if we give everyone the exact same treatment, which is not usually done in a clinical setting, but in a research setting, that's why we're going to get a lot of research results that are not extrapolatable to the big picture. And so part of really trying to get better treatments for eating disorders would be to try to, instead of breaking people into groups based on what their symptoms or behaviors are, is to break people into groups based on the origins of their symptoms and behaviors, because I think we would get better results for our medication treatments and other treatments if we were treating people who all had the same disorder rather than all people who have the same symptoms. And if you've ever heard me speak on this before, you know my story about the three bears. And the three bears all were coughing, and Goldilocks gives each of the three bears a cough drop. And Papa Bear says, "Oh my gosh, I feel so much better. Thank you, Goldilocks." And Mama Bear feels exactly the same and keeps coughing. And Baby Bear sadly passes out and they have to call 911. Well, why? All three of them were coughing. So why didn't the cough drop have the same effect? Well, if Papa Bear had a sore throat, then a cough drop helped a lot and he didn't cough anymore. If Mama Bear had tuberculosis, then coughing is not going to help at all. Perhaps I should update my example to say that Mama Bear had COVID and having a cough drop isn't going to help at all. Baby Bear, on the other hand, was already choking on something he ate. And so giving him a cough drop just completely obstructed his airway, and that's why he passed out. So if we haven't looked at the origin of why someone is coughing, we don't know what the treatment is. Now, granted, there are crisis and emergency responses that sometimes we have to deal with, but in any other situation, we have to identify what the root of the problem is before we can appropriately treat it. So here's my viewpoint that there really is no one treatment that works for all individuals with dysfunctional eating behaviors because there is no one cause. And so if you work in a in a model where treatment is individual based on the causes, behaviors, and core issues of each patient, you may be considered eclectic, and you may be sort of shunned by people who are one theory kind of treaters. It's not wrong to have one theory. It's just you have to accept that not everyone is going to improve with your one theoretical point of view. And it's not appropriate to consider them treatment failures. It's appropriate to say, our treatment has failed you. There may be a treatment that is more appropriate. That covers everything I wanted to say. I know it was a ton of words that I just threw at you. I will now open for questions so that I can clarify anything that I breezed over or that you would like to know more about.
Thank you, Jessica. Okay, we do have some questions, but
Great.
we've got some time. So if you all that are listening have more questions, please feel free to go ahead and type them in and send them, and I will get to them as we go. So Jessica, the first question, there were a couple of folks, Lauren, oops, hang on. I just lost my, there we go. There were a couple of folks, Lauren being one, and I think Natalie being another one. They had some questions about PANS. There specifically, if you could review that, that would be great. And secondly, the more specific question was, can someone with PANS still have a perception that they are eating less because of a fear of gaining weight and not just a decrease in appetite? Are you still there, Jessica?
Yes, I am. I'm still here.
There we go. Okay, great.
Okay. So thank you for asking for that clarification. So I mentioned concussion as someone who might have a decreased appetite or alteration in their appetite, yes. And I want to separate that out from PANS anorexia, which, yes, someone with PANS anorexia would have all of the classic hallmark symptoms of anorexia. I'm scared to eat. I don't want to eat because I don't want to gain weight. Those would be the symptoms of PANS anorexia, as opposed to dysfunctional eating related to concussion, which might just have a change in appetite, but it might also, because of the society we live in, again, be someone who expresses that they're scared to eat because of weight-related reasons. But yes, PANS anorexia would look exactly like anyone else with anorexia, but the sort of the hallmark clues that identify that someone may have PANS anorexia and needs to be evaluated for that are the acute onset. So in PANDAS, the A used to stand for autoimmune. Now it's been changed into PANS, which is the A stands for acute onset. So the acute onset is the key here, that you're not talking about someone who necessarily grows up in a weight-conscious home or in a weight-conscious sport, or anyone who would necessarily be exposed to that any more than all of us are always exposed to it in our society. But this is someone who, in an acute onset situation, suddenly starts to have these perseverations and worries about weight, maybe about specific kinds of food. It could also look like ARFID in some cases, where someone's eating less because suddenly these foods don't taste right or they don't feel right in my mouth. But this isn't someone who's had a lifelong issue here and they haven't had a traumatic event that would trigger this. It's someone who just out of the blue has this acute onset. It may also go along with some regression in other areas. So that might be, if it's a young child, they might go back to wetting the bed, for example. It might be someone who doesn't want to go to school, even though last week they were fine with going to school, expressing a lot of anxiety. And again, these are things that can be sort of ascribed to social problems, but they actually have a biological basis in the case of PANS. So I hope that clarified. And yes, ask more if I didn't answer your full question.
Great, thank you. Excuse me, we have a question from Carrie. She says, this gets my mind thinking about support groups for eating disorders. The clinician can begin to be aware of the anthropology of eating in the mix and rethink the treatment needs. Do you think this is an important way to better address support groups for individuals with eating disorders, as well as to informed loved ones about these factors, parentheses, psychoeducation?
Yes, absolutely. And I think that it's already being done. So that's the good news, is that you know that in a lot of treatment facilities, and even the way we practice individually as clinicians, we might recommend that someone go into a support group, for example, for someone who's lost a family member, or a support group for anxiety, or support group for neurodivergence. So we do practice like that. There's treatment facilities that have trauma treatment tracks, right, and addiction treatment tracks. And so not everyone goes into those groups necessarily. It's sort of identified as specific to that person's needs. I think that sometimes we treat it as a separate entity, though. Here's your addiction, so therefore you go to this addiction track one day a week, as opposed to how was your addiction related to your eating dysfunction. And same thing in some facilities, it's like, oh, you also have trauma, so you go to a trauma treatment track, as opposed to this is about how your traumatic events influenced your eating, or how living in a society that is constantly re-traumatizing you influences your eating. And so I feel like the psychoeducation piece is really helpful even for our clients and patients to say these things do interweave and overlap. And it may seem like on the surface, this is all societally induced stuff, but there may be stuff beneath that predated that. And some of the stuff that predates your sort of awareness even of society predates even your awareness of consciousness. It happened before you were even verbal. Some of this happened before you were born. And so talking about intergenerational trauma even, it's very eye-opening, I think, for people to realize that this has been a long time in the making. That's why it's sometimes a lifelong process to get out of it. Or to at least be able to manage it, because it's not something that just started overnight, even if a certain behavior, was only recognized or was only recognized as a problem fairly recently.
Well, and the next question I think is along those same lines. Maybe you can expound a little bit, Jessica. So this is from Amanda, and she says, how do you conceptualize treatment for a client with multiple causes, i.e. trauma, learned, and bio?
Right. So no one has multiple causes. They may have multiple impacts, but you have to keep going backward in time to what was sort of the original insult, let's say, because then it's compounding. So for example, I'm thinking of a patient I had who had what he called a binge eating problem and came to see me for his binge eating problem, but it actually was, he was overeating when no one was around because he was under eating when people were around, because he, verbally said he wanted to lose weight, and that's why he underate, because no one wants to see a larger person eating, la, la, la. So it sounded like a societal problem, right? Starts out sounding like a binging problem, then sounds more like an anorexia problem, then sounds more like a society-induced problem. But if you keep going back, you find out that this adult was adopted when he was a child, and he had a different body size than his brother, who was the biological child of his adoptive parents. And so at meal times, his brother, who was smaller, was allowed to eat as much as he wanted, and my patient was only allowed to eat one portion at a time. So it went all the way back to that traumatic experience, and really had to be handled in therapy way back, as opposed to me as a dietitian just educating about appropriate eating, because there was so much shame for him involved with eating anything that seemed in his mind to be more than what he should eat, or more than someone else would eat, etc., even though he may have just needed more. And so that's where it becomes a bit of a detective kind of work, because you do have to treat whatever the patient is presenting with. You can't say, well, you don't know your own experience, so I think there's more to this. But we can, gently say, I wonder what's behind that. I wonder what's behind that. I wonder what's behind that, until we sort of get to that aha moment. And I think the way that we now understand osteoporosis to have, we think of it as a disease or condition of the elderly, but we know it really starts out at quite a young age if someone isn't getting adequate nutrients. I think of eating disorders in the same way as, it looks like something that maybe started at, recently, but you can really research it back often into, childhood, and sometimes even pre-childhood, if you're talking about, the intergenerational trauma. So I know it sounds like, oh, well, someone could have all of these different causes, but they don't. They have all of these different influences, but there's a cause back at the beginning. And again, an example would be if someone had, let's say, a choking incident when they were a kid. Well, yeah, you could say, oh, well, they had this traumatic choking incident and that's why they don't want to eat whatever kind of food. But you have to look back and say, why did they have a traumatic choking incident? Were they, was it a situation where there wasn't enough food in the house and so you had to just eat everything fast or someone else would get it? Or was it that you had a child who had, enlarged tonsils, and so swallowing food was really a challenge for them from a biological perspective? So it's not giving up until you really find what is all the way back at the beginning. And that is what we would identify then as the cause, which other things might definitely, conspire with that. But there's one cause that ends up being the main root in my experience.
Got it. This next question is from one of our international attendees. Natalie is asking, what is your view on family therapy and CBTE, the prescribed model for treating eating disorders here in the UK?
And when they say family therapy,
that's a really big question.
Yeah. So family therapy, are they saying FBT? Do you think that's what they mean by family therapy?
I'm not sure.
Here we use okay.
They just say family therapy and then CBT-E, the prescribed model for treating eating disorders in the UK.
Got it. Okay, so I think that any model that says it is the method of treatment is a problem right there, because that's where you end up saying, oh, well, these people were non-compliant or this patient is a treatment failure. I think it's okay to try anything. I mean, I'm thinking back all the way to Peggy Claude Pierre, who used to spoon feed people, right? And, so anything that works is fine with me. It's just appropriate to say if this isn't working and to give it, I know with FBT, if that's what you meant, that there's a certain period of time if it's not working after 4 weeks. And, CBTE says based on your body weight, you get this many sessions. And as long as it's from the point of view of if we haven't been able to help you in this many sessions, then CBTE is not the answer. We encourage you to find something else, as opposed to this is how many sessions you get for CBTE. And if you're not fixed by the end of this number of sessions, then you've obviously been doing it wrong. So to me, it's not the modality itself. It's more the way that the modality is implemented for an individual.
Got it. This question is from Tiana. And they say, you can tell you have a wealth of experience and knowledge. Please share any books that have been really transformational in your understanding of these topics, parentheses, the anthropological, biological, or sociological as an RD over the years. So are there any books that have been really helpful to you in coming down this path?
Yes. Okay. So first of all, if this is dietitian Tiana from TikTok, I watch your videos. So hi. It might be a different awesome. Tiana, I suppose, but shout out to you if you are that Tiana. I would say, of course, intuitive eating is so useful, especially because they do talk about the inner anthropologist, which is so cool because as an anthropology devotee, no one ever talks about anthropology anywhere. So to read about it in intuitive eating is especially awesome. I would also say that any of Ellen Satter's books, because she talks about what normal sort of childhood eating development would be, and so few people actually have that normal progression that we're trying to sort of recreate it much later, but it helps to identify what appropriate progression of eating would be. I feel like the Feeding Your Extremely Picky Eater books, there's, one for teens and adults by Katja Rowell and Jenny McLaughlin, are amazing because they talk about how basically all dysfunctional eating behaviors are protective and have a reason. And they especially go into the biological aspect. For example, children who are protecting their airway by not eating, but it looks like bad behavior, that kind of thing, and neurodivergence. Those are the ones that come to mind. I think that for me, the things that have been most helpful have honestly been trying to read things that are not specifically directed at eating disorders, but are more about sort of the influences of society and culture in general. Because when you're reading a book that talks about, let's say, the experience of someone who, let's say, lived through Hurricane Katrina, as an eating disorder professional, you can identify, oh my gosh, yeah, they're talking about someone who's sitting on their roof for 3 days wondering if help is ever going to come. They didn't have any food. Of course, that's going to affect their eating long term if they have that, sort of susceptibility to an eating disorder. And so I feel like just being sort of open-minded about all the things that people experience. I know I've spent a lot of time this past 2 years reading things about the systemic racism in our country, and that's helped me understand a lot too, where different kind of ethnic foods, let's call them, are sort of considered, not healthy or not appropriate by the bigger system. That's been helpful to me as well in sort of undoing and unlearning some of the things that I was taught, whether it was in school as a, to become a dietitian, or whether it was, further back in time, but starting to understand the kind of ideas behind why people live the places they live are not always their choices, and why people eat the things they eat are not always their choices, and there's bigger impacts on things. So I guess I'm trying to think if there is a book that really addresses it, but I don't think I've ever seen one, although there probably are some. And if you find them and you let me know what they are, I will, share them with the group. But I think for the most part, it's using your nutrition or eating disorder knowledge to sort of layer on top of any kind of sociocultural type of thing that you're reading. Because, this has come from everywhere. I read an article about, how people with cancer were developing eating disorders because they were so praised for losing weight during their treatment, and then were scared to eat because they didn't want to gain weight back. How diseased of a society can you have where you're sort of celebrating weight loss as a result of cancer treatment, So that's the kind of thing that I feel like if you look around, you start to see it everywhere.
Will you say the name of that author again, Ellen, and spell her last name? We had lots of people
yes.
asking that question.
Ellen Satter is Ellyn. Ellyn. Satter is Satter.
Great, thank you. All right, we'll do one more question.
I thought of one more.
Okay, sorry,
but I thought of one more name. Irene Chatoor. Irene Chatoor, and Chatoor is spelled Chattoor. Irene Chatoor came up with a framework for childhood feeding disorders when that used to be a diagnostic criteria in the DSM, based on post-traumatic feeding disorder, disorder of attachment, disorder of separation. Any work by Irene Chatoor. I don't think she's written a book, but there may be articles or book chapters by her. Anything by her I would recommend too.
Got it. Thank you. We'll do one more question. We have too many to get to today. So, Jessica, is there an online presence for you that folks could reach out to you if they had a specific question? What's the best way for them to get in touch?
Absolutely. So first of all, I'm glad you said that, because I actually wrote a whole book. I compiled Q's and A's that I've been asked all the time, and the book is going to be coming out soonish. I'm reviewing the final version of it and editing it. It's called The Sleepless Dietitian's Big Book of Answers. But to find me online and give me more Q's for my A's, it's just jessicasetnick.com. It's just my name, and somewhere on there I'm sure is a place where you can sign up, and I'll make sure you get alerted whenever that book is ready. But also, yes, jessica@jessicasetnick.com is my email address, and you're welcome to email me a question anytime. I don't carry a patient caseload anymore. My whole job now is consultation with professionals, and if it's something you think I could answer that would take you an hour and a half to research online, but I just might be able to give you some help in a few minutes, I am always happy to save you that time, because it's so important, the work that everyone is doing.
And just so everybody knows, Jessica will get a list of all of these questions. So she'll get a printout of them.
Oh, good.
So Jessica will get to see, even if we weren't able to talk about it on the webinar today, she'll get to see all of those questions, and they might make it into the book. Who knows? Okay, here's the last question before we go. This is from Kayla, and Kayla's asking, for someone with a trauma-based eating disorder, is it best to wait until the patient is better able to cope with the trauma before providing nutrition counseling, or can it be done in tandem, and what is the best way to approach this?
So I think that it's individual, and the best way to approach it is individually, because unfortunately we have individuals who have specifically been traumatized around food, either punished with food, rewarded with food, and sometimes things that, you know, is hard for someone who grew up in a semi-functional family to contemplate, like, you know, given preferred foods after participating in unwanted sexual contact with a family member. I mean, there's so many things that can link food and trauma together. And so it's just really important that we sort of, you know, go at the pace at which is appropriate for the individual. And so, you know, I feel like medical stability always comes first. And so if someone is not able to nourish themselves without doing that trauma work, then we have to go there. But if there's a possibility of helping someone sort of, you know, get nourished into a better place where, you know, talk therapy may be more helpful, then I think that's okay too. I think there's also somatic experiencing work that can be done around mealtime, but it's hard to do when you have a big group of people in a facility. So it may have to be something that's done more one-on-one with sort of meal coaching and that kind of thing. And there's also a place for tube feeding. I know that it's not ideal in, you know, a lot of ways, but sometimes the act of eating or taking care of oneself is linked with so many traumatic experiences that it's important sort of to free someone from having to do that. So there's no one answer. To me, it's important to acknowledge and recognize the trauma. That's a given. Regardless of how you then proceed, it's so important to say, you know, to acknowledge it and say, this may be a real challenge based on some of the experiences that you've had. I hope that you'd be willing to share those with me, even if they feel shameful to you. I'm not judging at all. I want to be able to help you. And even if it's not something we can necessarily deal with right now, if, you know, we can keep a list of things that you do want to talk about when you're ready for EMDR, or, you know, whatever the case may be. I just think, you know, if you haven't been in a situation, it's hard sometimes to comprehend, you know, how reminiscent eating can be of, you know, terrifying and terrible experiences. And so we just have to be very open that the way we look at something is, you know, definitely not the way necessarily someone else does. And I'll just give the example of a patient who she did not like beans as a child. And when she would say she wouldn't eat her beans, she would get beaten by her parent with a belt. And so she went to a facility for eating disorder treatment. And per her report, obviously it's not the facility that any of you work at, she said that she was told when she said she would not eat beans at her meal time and why, that she, after the meal, had to stand up in accountability group and say to her peers that she was not abstinent from her eating disorder because she had refused to eat everything on her plate. And I personally feel that that is not the way to help someone heal from trauma. So, you know, it's easier to say, here's the wrong way to do it than here's the right way to do it, because there's probably a lot of right ways, because acknowledging the trauma, I think, is already, you know, on the right track.
Thank you. That was amazing and so full of wonderful information and so helpful. And I so appreciate you being with us today, Jessica. And thanks for your patience to Jessica and to everybody with our technical difficulties. We worked through it. We were able to hear Jessica, and that's the most important part. So we're grateful that you stuck with us for that. A couple of reminders. When I end the webinar here in just a minute, an evaluation will pop up on your screen. If you take just 30 seconds or so to complete that evaluation, that would be really helpful. That's a continuing education requirement for us. It's completely anonymous, so feel free to be candid. We tabulate those results and send those to the CE approval entities. And then about an hour from now, you'll receive a separate email from GoToWebinar. It will look similar to the email that you got when you registered. It will be a separate email from GoToWebinar with the link to take the online test. When you click that link and take the test and pass, then your continuing education certificate will automatically be downloaded to your computer. So if you don't see it on your screen, check your downloads file. Thank you again, everyone, for attending today. We hope you can be with us next time. Our next webinar is Wednesday, September 15th. Christy Shohet is presenting. She's an amazing eating disorder clinician in the Boise, Idaho area with significant experience. I think you all will enjoy her presentation. So we look forward to having you join us then. And in the meantime, everybody stay well. Bye-bye.